In today's episode, we're going over a case study of a patient post-operative ACL reconstruction, and we're also going to go over her pre-op rehab. Let's get it rolling. First and foremost, thank you so much for watching and supporting me. You truly allow me to do what I love for a living. My name is Dan Pope. I'm a physical therapist, coach, and meathead. I love all things fitness tremendously. It's been my biggest passion since I was a little guy, right? This is the Fitness Pain Free Show where we help coaches and physical therapists like you get your patients out of pain and back to training. If you're watching this on YouTube, please hit that like button. It helps me out tremendously. It sounds really stupid. And, when I am watching YouTube, I very rarely hit the like button. I should more frequently because it helps me out. Okay. Please comment if you have any questions, and then subscribe to the channel if you haven't already. And then if you're listening or watching this via podcast, yes, there's a video podcast up on Spotify. Please leave me a positive rating and review. That, again, helps me out tremendously. If you want to go that extra step and support me further, consider subscribing to Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for trainers and physical therapists. It's premium content from me. I've been updating this for 5+ years. There's over 100 webinars, ebooks, and complete guides. You have access to a private Facebook group. So if you have any questions, I'll answer those. You can also decide upcoming podcast topics. I've gotten a lot of really good topics from you guys over the course of time, which has been a lot of fun. And you get started for just $1. It's kind of ridiculous how cheap it is, right? I'm probably going to bring that price up in the future. And you can cancel anytime. So if you're interested, I'll put a link in the show notes, but you can also go to fitnesspainfree.com, go to programs, and click on Fitness Pain Free Insiders Online Library to get started. Before we get started today, I want you guys to download the evidence-based guide to exercise after ACL reconstruction. So I'm in a really nice infographic that's going to help you out with all of your patients when you're trying to figure out which exercise to give them and how to advance them over the course of time. I'll put that link in the show notes. We go over why do we care about exercise selection after ACL reconstruction, how to dose exercise for ACL reconstruction patients, and also when is it safe to start open chain knee extensions, okay? So link in the show notes, definitely check that out. It's going to help you out tremendously, okay? Free resource, go grab it. In today's episode, we're going over part 2 of our ACL reconstruction case study. If you haven't listened to part 1 yet, make sure you do that before moving on. Let's get rolling. So what did the physical therapy program look like just after injury, right? So I ended up seeing this patient, I want to say 1 to 2 weeks after her initial injury, right? And I basically gave her a lot of repetitions of quad exercises. If you guys are watching this on YouTube, phenomenal. You can see the program right in front of you. Same thing on the video podcast. I'm going to read through this for the folks that are listening to this via the audio podcast. So I basically prescribed 2 sets of 15 to 25 repetitions of each movement, 2 to 3 times a day, and adding light weight as you're able to tolerate it well. Okay. The reason why I do lots and lots and lots of repetitions is because we're trying to restore neuromuscular control. Okay. So that quad does not fire really well after this initial injury. So the analogy I give my patients is that if you want to be a really good painter, you have to get a lot of reps in. Okay. You're building that motor control of being a better painter. Okay. So you can paint for hours and hours and hours every day. You're going to be a lot better at painting long-term than someone that does, let's say, 2 hours, twice a week. Right. So I think early on, we're not doing strictly strength training. We're trying to build neuromuscular control. So I favor a lot of repetitions. The other reason why I favor a lot of repetitions is because I want to start blood flow restriction training soon. Okay. And when you do BFR, you generally do it with high reps. But I want to make sure that a patient can tolerate high repetitions without BFR before I throw them into that BFR realm, just because the stress with BFR is a lot more. Okay. So what exercise we're using? A lot of quad sets with the heel propped up, roller underneath of the heel to make sure we can get full range of motion, right? To bend that knee a little bit backwards. Straight leg raise, again, prop under the heel. Long arc quads, internal knee extensions, standing, seated knee bends, and on-chair knee bending. Okay. When she came in for physical therapy, we did all of these exercises with BFR as well as neuromuscular electrical stim, because this can help to attenuate the loss of muscle mass. It can also help with that neuromuscular control, getting that quad to fire a bit better. Okay. We also did some strengthening work for the contralateral limb 3 times per week. This was single-legged deadlifts and single-legged squats. Okay. From a conditioning perspective, we end up doing stationary bike by 3 times a week, 20 to 30 minutes with a low to moderate resistance, right? And generally speaking, I give a program, okay, and I see how the knee tolerates it. Are we getting a lot of swelling? Is the swelling going down? Is the range of motion improving? And if all those things are moving forward, then we can advance, right? And advance we did. As she was able to tolerate more and more, we just gave her more and more, right? So this is her strength program. This was her Monday, Wednesday, and Friday. There's only 2 days. So what we end up doing is day one was on Monday, day two is on Wednesday, and then on Friday you go back to day one, and the following Monday will be day two. So just looping between these day one and day two with a day's rest in between, right? So we're working on goblet squats, split squats, band sidestepping, single-legged deadlifts, seated knee extensions, and ankle weight hamstring curls on day one. On day two, kettlebell deadlifts, step ups with toe drag, very quad dominant movement, single leg calf raises off the step, single legged squats to a bench, sideline hip abduction with an ankle weight, and sissy squats with a terminal knee extension, right? So a lot of quad stuff there. From a PT perspective, when this patient was coming in for physical therapy, like I said, she did once per week. I worked on her range of motion. We did blood flow restriction training. We did neuromuscular electrical stim. We worked on neuromuscular control and balance drills, right? So think about standing on a Bosu ball while someone messes with that Bosu ball and your patient balances on one leg, okay? Drills like that. And then from a conditioning perspective, 3 times a week, we worked up eventually to 45 to 60 minutes, which she was pretty happy about because, like I said before, she loves fitness and this makes her feel like a real person if she can actually do this stuff. So she was very grateful to be able to do that. So, what are the results of our pre-operative physical therapy? And this is a little bit sad, and the reason being is because a lot of these patients end up feeling really, really good prior to surgery, and then they get surgery and they feel like they're right back to square one again, which is a bit unfortunate. Okay, ultimately, I think this patient made the right long-term decision, getting this ACL reconstruction. But generally speaking, she was doing so well that she felt like she didn't need surgery. And that's what you're going to find oftentimes if you do a good job with preoperative PT and you have enough time to do enough PT prior to surgery. And that's okay, right? You kind of want that sensation. If your patient is feeling pretty dang good, that's a sign they're probably ready for surgery, despite them also feeling like, what the heck am I getting surgery for, right? So her range of motion was basically symmetrical prior to surgery. It's usually a bit stiff at the session start, particularly into extension, right? But it would clear right up as soon as we did some gentle range of motion. Her swelling was minimal to no, right? Didn't really notice much at all. And her quad strength, this is actually very, very important. She was 88% symmetrical. Now think about those guidelines from University of Delaware. They're looking for 80% symmetry. She was around 88% symmetrical. So the way we test the quad is we have someone sit at the edge of a table, right? And then we put a belt around the back leg of a table. There's an image of this in case you wanted to see this, right? And you're watching the audio version of this. And then we wrap the belt around the lower part of the leg and put the strap around the handheld dynamometer that's pushed up against the leg of the table, okay? The knee angle, we're trying to be around 70%. The reason why we use that is because that's the knee flexion angle that we see most in our medical literature, right? So we're trying to have normative data with our quad strength testing, okay? Have the patient just press as hard as they can. It's kind of like an open chain knee extension, right? Which is very safe if you're below about, let's say 50 degrees or above, 50 degrees. So 50 to 90-ish is very safe. We do it at 70. She had 88% symmetry. So her right quad strength was at 74. Left, the going to be surgical side was at 65. Okay. So pretty dang good. She's ready for surgery. We hit all of her criteria, right? This was about a 2-month period between when she got hurt and when she went in for surgery. Unfortunately, her surgery got a bit delayed. COVID problems, right? Everyone's dealt with some of this. But it may have ended up being good because she gained a lot of extra little strength at the very end there, which I like to believe is going to help her in the long term, right? So she went in for ACL reconstruction surgery, and it was a success. Woo! Right? So what surgery she have? Well, ACL reconstruction. We knew that. She used a cadaver allograft. We knew that, right? We made that decision because of her age and the activities she wants to get back to. And for the ease of rehabilitation, what I will say is that despite this being a bit of an easier rehab, it doesn't mean that you should progress faster. Okay. So these folks tend to start feeling pretty dang good by about 6 to 8 weeks. However, depending on the study that you read, this is probably when the graft is at its weakest. Okay. So when they put that graft in initially, it's actually quite strong. And then it goes through a period of time where it gets weaker, 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 right? The weakest point is probably somewhere around week 6 to 8. And then it gets stronger the next several years, okay, through a process called ligamentization. So we have to be a little bit cautious because when these patients start feeling really good, typically it's when that graft is at its weakest. All right. So definitely keep that in mind. It's one of the reasons why we have to be cautious pushing the cadaver grafts, right? The other piece is if you look at Delaware's ACL protocol, they don't like to return these folks to sport until 12 months. So if you use an autograft, hamstring or patellar, they like to return around 9 months. But if you're doing an allograft, a cadaver graft, they don't like to return until 12. Okay. And that's because of the graft choice. We know those have an increased likelihood of tearing again, right? We don't want that to happen, failure. The other anecdote I'll give for you, and again, it's an anecdote, so take this with a grain of salt. I've seen a few folks where the body just seems to reject the cadaver allograft. So your body just eats it up. It's like, this is not a part of my body. I don't want it here. I'm going to get rid of it. Right. And I couldn't find any research. I talked to Lenny about this, my coworker, who's a big ACL guy. We couldn't find any research on the rates of your body doing this, right? Although we've both seen this. So it's definitely a bit of a risk. And, the two of us have seen this enough to be a little bit cautious when prescribing the cadaver allograft, but this is a story for another day. So apologize for getting off track. And in terms of what to do with the meniscus, they couldn't repair anything, right? So they just did a meniscectomy and, ended up trimming the area out, didn't repair anything. And this is going to be important because we're going to be able to go a little faster with our rehabilitation just because we didn't have to respect that meniscus repair because it didn't occur, right? So what kind of contraindications do we have early on after surgery? Well, for one, the surgeon wanted partial weight bearing for the first 4 weeks, right? With crutches. Now we know the surgeon, right? We like him quite a bit. And to be honest, this is quite conservative. So generally speaking, you're back to full weight bearing a lot quicker, right? Maybe by about 2 weeks or so. Some surgeons are faster than that, like maybe like a couple days after surgery, people are walking full weight bearing. Really depends on the surgeon. But the reason why this surgeon wanted the partial weight bearing for the first 4 weeks is simply because this was a cadaver graft, right? And we kind of know that these tend to get better pretty quickly. And we're just trying to respect that a bit. We don't want to push stress on this too soon, right? And that's the reason why there's a partial weight bearing status for the first 4 weeks, right? The only problem is that anytime that you're making someone non-weight bearing, especially, but partial weight bearing, you're probably going to have a bit more atrophy, okay? Because we can't load this the way we want to. We're probably going to get a little weakness. So there's always that argument of pushing weight bearing sooner, just because if that's not going to damage the graft, we want that because we want that stress through the quad. We want to make sure we're not getting the atrophy because we're going to get it. We know that quad is going to get weaker and we're trying to do whatever we can to attenuate that, right? So she had a brace for the first 6 weeks. She was locked into extension for 4 weeks and then had to wear it for a total of 6. And she was recommended to start physical therapy a week after surgery. And prior to starting physical therapy, she was doing basic quad exercises like quad set, straight leg raise. She was doing heel slides, basically post-op day 1, right? In terms of whether or not the surgeon liked open chain knee extensions, so the surgeon's protocol actually has short arc quad starting at week 1, right? So if you watch my last episode, you'll know that you've got the most stress through the ACL graft between 0 and 30 degrees of knee extension, right? Which is basically a short arc quad. So the surgeon is not concerned about open chain knee extensions. We can start that kind of right away. Just because we're allowed to start it right away, you'll see I don't push it. I don't push it a ton, right? And you'll see that we actually get the quad back over the course of time without having to be aggressive with open chain knee extensions. So she started up her physical therapy at week 1, right? So things I'm on the lookout for on the first visit is I want to make sure that the incisions are looking good. Are they dry? Are they healing? Are there any signs of infection, signs of DVT, right? We also educate the patient about these things so they know it. Do keep in mind that oftentimes these patients are getting this information from the doctor when they're completely out of it, right? When they just had a surgery and they're really confused, okay? So it helps if the physical therapist reiterates that. And every once in a while, you will pick up some of these problems. I think I recently sent an ACL reconstruction back to the doctor because they were developing an infection and they were placed on antibiotic. And I've had 2 in recent memory where that's happened. So you do have to be on the lookout for that. And the last thing you want is a big, infection in that joint or DVT or, just be on the lookout. It doesn't happen that often, but it does happen. Okay. So she had moderate swelling. There's quite a bit of bruising. If you can see the imaging there, that is her leg after she's had surgery, right? It's going to happen. You're definitely going to see all that bruising. She had a quad contraction deficit. So her quad just didn't fire very well. I kind of rate it as moderate, although it's not a very objective system. If it didn't fire whatsoever, that would be 0, right? Minimal would be a little bit of firing. And then if she could make the same quad muscle on the left versus her right, then there'd be no deficit. I rate it as moderate, okay? In terms of range of motion, she did not have the meniscus repair, so there were no restrictions in terms of range of motion. Her flexion at that first week was 110. On the other side, it was 147. Her extension was positive 4 degrees, so she was 4 degrees away from neutral on the surgical side. And on the non-surgical side, she has 2 degrees of hyperextension, so we want to try to restore that as much as we can. So again, if you guys are looking for a really good evidence-based protocol that I'd recommend, these are developed by the folks over at the University of Delaware, right? Lynn Snyder Mackler, if you ever heard of her, had a lot of work into developing this protocol. But we have our own protocols that we use, and we also utilize a lot of what the surgeons recommend. So I'm not blowing through the surgeons' recommendations. I like to follow their protocols, right? I think that's important. Find the right surgeons that have the right protocols, right? So don't refer your patients to surgeons that you don't agree with their rehab protocols. But if you're looking for a good protocol that I would recommend, you can check out Delaware's. And that is my first reference. And I'll leave a link to the show notes so you can check that out, right? Because I'm not going to give you a protocol today. I'm just going to walk you through what we did with her. So what are my decisions early on? What is that decision-making process? So for one, you want to protect the graft, okay? So the speed of progression with exercise is going to be very important. Again, if you want to see an evidence-based guide to exercise selection after ACL reconstruction, check my last Fitness Pain Free Show episode. I go over that in depth. We also want to prevent atrophy as much as possible. Like I said, this quad is going to get weaker and weaker over the course of time. Okay. There's going to be a period of time where it gets weaker before it gets stronger. So we're trying to prevent that atrophy as much as possible. We want to try to maintain our sport and physical qualities as much as possible. So we basically want to try to maintain as much as possible because it's really hard to build back up once you become deconditioned. If we can maintain, phenomenal. Okay. It's a big win. And we use swelling and pain as a bit of a guide, right? So if we're doing enough, you should find that they're getting better strength-wise, range of motion-wise, and they're not getting more swollen, more painful over the course of time, okay? So if you're getting more swollen, more painful, maybe you're pushing a little too fast, okay? And if you're not at all and they're not progressing adequately, maybe you have to push them a little bit more, right? And the idea is we have a slow ramp up over the course of time, and our long-term plan is return back to skiing, like we said previously. So what is my physical therapy plan of care for this patient? We want to do physical therapy 2 times a week if able, right? I want to provide a home exercise program. And here's my decision-making process. I'm lucky. I'm in an out-of-network place. We can do whatever the heck we want to do. We're not pressed to see patients more frequently or less frequently, right? Obviously, if I see the patient more often, I make more money. So there's that incentive. But generally speaking, I like to try to make decisions based on what's best for the patient, not what puts the most money in my pocket, which is phenomenal for me, right? Because I don't feel bad at the end of the day for forcing people into more visits than they may need. So if this patient was having more pain and was have problems with gaining their range of motion back, I may recommend more physical therapy, right? However, if their pain is great, the range of motion is progressing quickly, and the patient is having trouble, let's say financially affording my services, then I do less per week, okay? And we actually ended up moving to 1 time a week for this patient just because she was doing so well. Her range of motion was getting better. Her pain levels were minimal. She was an all-star. So I didn't think she needed to be in twice a week, right? And to be honest, I don't know that she, made any less progress because she was there one less day. I think she did quite well, right? So what do we do to restore range of motion in this patient? So the process is very similar to this patient prior to surgery, okay? So every session, we like to measure the range of motion at the session start, get an idea of how it's progressing to see if we're giving too much exercise or not enough exercise. We make our decisions based on the progress over the course of time, okay? And that's going to dictate the tolerance to exercise too. So if you're getting stiffer, there's a chance you're giving that patient too much and or they're not doing their exercises, right? So you kind of have to parse that out and figure what the problem is, okay? So to work on extension, I'll do some soft tissue work to the gastroc as well as the hamstring to promote more knee extension. And if we're really limited into knee flexion, I do more work to the quad, right? Patellar mobs, superior and inferior. So inferior mobs are more for knee flexion. Superior mobs are more for knee extension, okay? So you can choose which mobilization to do more of based on where your limitations lie. And I also do basic range of motion with overpressure. So I may seated knee extension at the end of the table for flexion. And then for knee extension, just the patient lying supine on their back, their heel propped up, me pressing into more extension with my hand over their kneecap, right? We also prescribe a lot of homework. I like constant, frequent, low intensity motion with the priority on restoring extension. And I like to prescribe my patients quad sets, terminal knee extensions, and assisted knee extensions. So the patient sits with their heel propped up and they extend their own knee with a little bit of overpressure from their hand. I like a lot of frequency here, right? Frequency over intensity. So we're doing these exercises 3 to 5 times a day, right? Even up to every hour, right? To really improve that range of motion. You got to watch out for pain and swelling. If you're doing a little too much, then you may get more stiff, more painful, more swollen. That's not what we want. And the other piece is that if you're not having progress with this plan, you can also add some low load, long duration stretching, which would be the patient lying supine on their back with a foam roller or some sort of prop underneath the heel. And then you have an ankle weight starting with a light weight above the kneecap, pushing that knee into more extension. Okay. You usually start with about 10 minutes per day, but you can work your way up to 60 minutes per day. So I stole this from Lenny Macrina, and he actually recommends 3 by 20-minute sessions of low load, long duration stretching with a light ankle weight above the knee for those stubborn knee extension folks that just aren't regaining the range quickly after surgery. In terms of flexion, we're trying to do the same thing. So we're doing constant, frequent, low intensity motion. For flexion, this is typically heel slides, seated knee bends, chair knee bends. Basically choosing 1 to 2 exercises that are comfortable and convenient, doing this 3 to 5 times a day for 10 to 15 repetitions, and just watching for swelling and pain. If it's getting too painful, too swollen, we might have to back off a little bit over the course of time. Like I said, flexion is not quite as important as extension. And some folks, they're very, very stubborn with their flexion range of motion. And you may decide to employ some of the low load, long duration stretching as well. We have this chair, this torture chair called a flexionator in our office where it just bends your knee. There's a crank that bends your knee, and you just sit with a low level stretch for a long period of time, which is pretty god awful, but it is effective. You can also do the same thing with a chair close to the wall where you kind of bend your knee with assistance from the wall and just maintain that bend for a period. You can also do it seated at a chair where you bend your own knee and just hold that for a period of time as well, which is helpful for folks that are maybe working for the majority of the day and they just want a nice stretch on that, and they're a little stubborn in terms of improving their flexion range. So what did the strength look like from week 1 to 4? So initially, she was partial weight bearing. And again, this is because she was a cadaver graft. The surgeon was just being cautious. Okay. So we weren't able to do a bunch of standing exercises like squats and deadlifts and that type of thing. We did do those as soon as we were able to, but we weren't able to initially. Okay. So in terms of working on the quads, which again is one of the most important parts here, we performed all of our quad exercises with neuromuscular electrical stim and MES with blood flow restriction training. Now, we have some decent research to show that blood flow restriction training helps to attenuate some of that loss in muscle mass early after surgery. Okay. The neuromuscular electrical stim is kind of the same, helps get that quad back on board. And we're trying to do whatever we can to do that. Okay. In terms of the exercises we chose, there's mostly quad sets, straight leg raise, long arc quads, and supine knee extension. Okay. And the set and rep range, because we're doing BFR, was 30, 15, 15, 15. But just keep in mind, we didn't start with those reps. We started with your generic 3 sets of 10-ish, just to make sure the patient tolerated the movements well. And once we know they can tolerate the movements well, then we increase the repetitions. So I've made the mistake in the past of going straight to 30, 15, 15, 15 and making my patients really, really sore, right? The other thing about BFR is that you have to be cautious in terms of the actual wound, right? So we waited for about 2 weeks, but I've also had some post-op ACLs where I've waited up to 8 to 10 weeks just because the wound didn't look like it was healing very well. And once we started BFR, the wound got a little seepy, right? So you start pushing some fluids out of the wound, and that's not good, okay? You don't want to drive an infection. So I wouldn't push the blood flow restriction training unless the surgeon is comfortable with it and that wound is healing well, okay? So just keep those things in mind, right? In terms of working accessory muscles, so not the quad, we were doing generic set and rep schemes. So 3 sets of 10 to 12, 3 times per week. We worked the glutes, the hamstrings, the calves. This was with movements like seated calf raises, seated knee flexion, standing hip extension versus a band, and standing hip abduction versus a band as well. Okay, so try and hit all of those accessory muscles too. So what did the home program look like? So when this patient went home, what was she doing for the first 4 weeks? So basically, we're going to war on the quads. And that's one of the things I tell my patients, just so they understand the importance of getting these quads back on board. I just want to let them know, like, hey, we're going to war on these things. We need to do a lot of work to get them back up, okay? So I gave the guidelines of doing 2 sets of 15 to 25 repetitions of each movement, 2 to 3 times per day, adding lightweight as able. And we're doing movements like quad sets, straight leg raises, long arc quads, and supine knee extension. So we're just doing a lot of exercise to restore neuromuscular control. Like I said, that quad is like a bowl of mashed potatoes after you've had ACL reconstruction surgery, okay? it's not that strong and the muscle doesn't fire well. And we're trying to get that muscle back on board. So a lot of repetitions is needed to restore the ability to that muscle to work well. Okay. And that's what we prescribe. Okay. Just keep in mind that it's not too much and the patient is not getting more painful, losing range of motion, and all of those things. You might have to either decrease or increase the amount of work you're giving them. So what were we doing for the contralateral limb? So our patient's partial weight bearing, so she can't put all her weight on the surgical side, but doesn't mean we can't train that contralateral limb. Keep in mind that research study I talked about earlier on in this lecture series. Basically, training the contralateral limb increases strength on the surgical side. Okay, so you can betcha we're working that contralateral limb. And that means single-legged deadlifts, single-legged squats, calf raises. We're doing twice a week strength training, 3 sets of 8 to 10. So kind of similar to a general strength training program you would see, right, for someone who didn't have any sort of surgery prior. Okay. In terms of conditioning, we did it every single day. My patient loves to exercise, right? Definitely a good thing for cardiovascular health and maintain their fitness as much as possible. She was using an upright bike and she would go for about 20 minutes per day. And she wasn't using much resistance initially, right? However, bike riding is not very much stress on the ACL graft, even if you start to increase the speed. So it's not something I'm super concerned about. But again, we're throwing a lot at this thing in the beginning, and you want to make sure that you're not throwing too much by saying, okay, do all these quad exercises, all these range of motion exercises, and then hit the bike hard, right? You might cause a lot of swelling, pain, discomfort. We just don't want that. So we have a maintenance dose of conditioning, and we can always increase that over the course of time. So now we're at week 5, and the partial weight status has been removed, and things start to get a little bit interesting. Okay. Now I have what I call a transition week. Okay. So if you have a patient that goes from non-weight bearing to weight bearing or partial weight bearing, right, to full weight bearing, that's a big transition. Okay. And during this time period, you're also allowed to do things like squatting, right, single-legged deadlifts, and all sorts of more challenging motions. Okay. But if you throw all of that at your patient all at once, you run the risk of making them really sore and really painful. Okay. So I call this a transition week. And my biggest focus at week 5 is gait, right? Because we haven't been able to walk in the past several weeks. So I want to focus on getting the ability to walk back. All right. And things that we focused on that I see a lot after ACL reconstruction is that folks just don't like to get that leg straight when they put weight on it. Okay. So I tell folks when they put weight on the surgical side to get tall. So every single step you take when that surgical leg is down, get nice and tall. And that's to minimize the amount of knee flexion in single-legged stance. Okay. We also do a lot of work on step length. So oftentimes after surgery, these folks will take a short step, long step, short step, long step. We work on getting that symmetrical via cues. We also work on step speed. Okay, so how fast you're taking steps. These folks tend to take very slow steps after surgery. And of course, they're just being careful. And that makes sense. But we need to improve that over the course of time. We also work on step symmetry. So I use a metronome, right? So if you haven't heard of a metronome, it's something that beeps at a consistent frequency. So beep, 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 beep. Oftentimes after surgery, you'll notice that folks will take a fast step and then a short step, fast step, short step. We don't want that. We want symmetry between step frequency, right? So I'll let the metronome play and have patients try to match that metronome as they go. And the last piece that's really important is that we don't want to have a ton of steps up front. Okay. So let's say that you're partial weight bearing week 4. And then as soon as you get into the next week, week 5, you go to Costco and do all your grocery shopping, right? You may really get that thing to swell up and you might be pretty painful afterwards. We want to make sure the patients understand that we need a slow ramp up of steps throughout the course of the day. Okay. And I have my patients use a pedometer so they have an idea of how many steps are taken and we can slowly ramp up over the course of time. Okay. During this same week, I like to introduce bilateral loads. So this is squatting and deadlifting. Okay. And I think when we think squats and deadlifts, we think about adding load, right? I'm not. I'm just doing this unloaded. So a partial range of motion squat, which is very little stress on the ACL graft, and a partial range of motion deadlift, right? Sometimes I give them a little bit of weight, but very little. And this, again, very safe for the ACL graft. But we're really just focusing on symmetry. Okay. We're not focused on load at all. And I like to start these on, I'm lucky enough to work in a facility that has force plates. So basically you stand on the force plates and it tells you how much weight you have on your left side versus your right side. It gives you a little bit of video feedback so you can correct that in real time, which is super nice. If you don't have access to that, you can do video feedback or just take a video of the patient and show them what they look like. Or you can also exercise in front of the mirror so you can see if you're shifting to one side. Okay. And generally speaking, we're focusing on partial ranges of motion, unloaded motion, and we're just working on symmetry, trying to restore the ability to move equally between the left and the right. Okay. Also, keep in mind, we're at week 5. Week 6 to 8 ish is the weakest time period for the graft. So, despite folks being able to do more now, it's also a period of time when the graft is quite weak. So, we have to be careful, right? If you guys want a very, very in depth guide to exercise prescription and progressions for knee pain, like ACL reconstruction, but as well as patellofemoral pain, meniscus pathology, and a couple others, and definitely consider subscribing to Fitness Pain Free Insiders. Inside of there, I have a lecture called Exercise Prescription and Progressions for the Knee. We go super in depth on where to start exercise wise and how to progress over the course of time, how to know when you need to pull back, when you have to pull forward, the differences and the nuances between different pathologies. I go super in depth. So I'll put a link in the show notes to check this out, fitnesspainfree.com. Click on the programs link, click on Fitness Pain Free Insiders online library, and check out this exercise prescription and progressions for the knee lecture. Great next step for learning more about exercise prescription and knee pain. If you guys are interested in any of the references, I'll leave that in the show notes as well. Reference number 1 is that Delaware ACL Reconstruction Physical Therapy Protocol. So definitely check that out to learn a bit more. That is it for today's podcast. Thank you for joining. On the next one, we'll continue our talk on our case study after ACL reconstruction. Stay tuned.